Welcome to Studious. This lecture is your complete visual clinical pathway for the emergency management of ST elevation myocardial infarction, STEMI, covering every critical decision point from the moment a patient walks through the emergency department door to the day of discharge. STEMI is one of the most time-sensitive emergencies in all of medicine. Every minute of continued coronary artery occlusion destroys approximately 1 billion cardiomyocytes, cells that the adult human heart cannot regenerate. Globally, ischemic heart disease accounts for over 9 million deaths annually, making it the single leading cause of mortality worldwide. The defining characteristic of STEMI that separates it from other acute coronary syndromes is complete transmural occlusion of a coronary artery by a thrombus, not partial blockage, but total cessation of blood flow through a major epicardial vessel. This produces full-thickness ischemia across the ventricular wall and the characteristic ST segment elevation on the 12-lead ECG that gives the condition its name. The goal of this lecture is to give you a systematic, algorithmic framework that mirrors the real-time decision-making process of an emergency cardiologist: diagnosis, acute stabilization, complication management, reperfusion strategy selection, post-PCI care, and long-term secondary prevention. Whether you are preparing for USMLE Step 2 CK, MRCP, MBBS finals, or clinical practice, every protocol in this video is grounded in current ACC and ESC guidelines.
The recognition of STEMI begins with pattern recognition, rapidly integrating the patient's risk profile, presenting symptoms, ECG findings, and cardiac biomarkers into a unified clinical diagnosis. Our index case establishes the classic STEMI presentation. A 55-year-old male arrives with severe, crushing substernal chest pain that radiates to the left arm and jaw. His risk factor profile is textbook for accelerated atherosclerotic disease, a current smoker, 12 years of type 2 diabetes mellitus causing endothelial dysfunction and accelerated plaque formation, and hypertension with poor medication compliance, meaning his coronary arteries have been exposed to sustained elevated pressure, turbulent flow, and oxidative stress. The ECG is the most critical and immediately available diagnostic tool. In this case, ST segment elevation is present in leads V1 through V4, the anterior precordial leads, indicating occlusion of the left anterior descending artery, or LAD. The LAD supplies the entire anterior wall and apex of the left ventricle, making anterior STEMI the most hemodynamically consequential infarct territory. Cardiac biomarkers, troponin I or T, and CKMB are elevated, confirming myocardial cell death. The diagnostic triad is complete: ischemic chest pain plus anterior ST elevation plus elevated troponin equals classic anterior STEMI confirmed. The clock starts the moment the first ECG is obtained. Every subsequent clinical decision must be made with time as the primary constraint.
The moment STEMI is confirmed, a 6-drug acute stabilization protocol must be initiated simultaneously while the catheterization laboratory is being activated. Each drug addresses a specific, distinct pathophysiological mechanism. Oxygen is the first intervention, but with a critical nuance. Supplemental oxygen is administered only if the patient's oxygen saturation drops below 90%. Routine oxygen in normoxic patients actually generates reactive oxygen species and may paradoxically worsen myocardial injury, a finding from the AVOID and DITO-OX AMI trials. Aspirin, at a loading dose of 325 milligrams, is administered immediately and chewed, not swallowed whole, to accelerate buccal absorption. It irreversibly inhibits cyclooxygenase 1, blocking thromboxane A2-mediated platelet aggregation. It carries one of the highest mortality reduction benefits of any acute intervention in medicine. Clopidogrel, a P2Y12 receptor inhibitor, is added to provide dual antiplatelet blockade, attacking platelet aggregation through a completely separate receptor pathway. This combination of aspirin plus a P2Y12 inhibitor is called dual antiplatelet therapy, or DAPT. Sublingual nitrates are administered for rapid venodilation via buccal absorption, reducing venous preload and cardiac oxygen demand, while also providing coronary vasodilation.
High-dose atorvastatin at 80 milligrams provides acute plaque stabilization beyond its chronic lipid-lowering effect. And anticoagulation with low molecular weight heparin, preferred over unfractionated heparin for its predictable bioavailability, inhibits thrombin and blocks further clot propagation within the occluded vessel.
Two drug classes in STEMI management carry the most powerful and well-established mortality reduction evidence: beta blockers and ACE inhibitors. And understanding both the rationale and the contraindications for each is essential for examination success and clinical safety. The most common cause of death in acute myocardial infarction is not pump failure in the first hours. It is lethal arrhythmia. Ischemic myocardium is electrically unstable. Heterogeneous conduction through zones of normal and ischemic tissue creates re-entry circuits that generate ventricular tachycardia and ventricular fibrillation. Beta blockers act as direct antiarrhythmic agents in this context. They reduce sympathetic-driven automaticity, slow conduction through the AV node, decrease myocardial oxygen consumption by reducing heart rate and contractility, and have been shown in landmark trials, including ISIS-1, to significantly reduce acute mortality. ACE inhibitors, such as ramipril or enalapril, block the renin-angiotensin-aldosterone system's maladaptive response to myocardial injury, preventing progressive ventricular dilation and remodeling that would otherwise convert the infarct into chronic heart failure. However, both drugs carry absolute contraindications that must be checked before administration. Beta blockers are absolutely contraindicated in the presence of hypotension, systolic blood pressure below 90 millimeters of mercury, bradycardia, heart rate below 60 beats per minute, and active bronchospasm in asthma or COPD, where beta-2 receptor blockade can precipitate fatal bronchoconstriction. Administering a beta blocker to a bradycardic hypotensive STEMI patient can precipitate cardiogenic shock. Despite optimal acute pharmacotherapy, STEMI patients frequently develop acute hemodynamic or respiratory complications that require immediate, targeted escalation. The triage algorithm follows a conditional if-then logic that must be executed rapidly and decisively. Complication 1. If the patient continues to experience severe chest pain despite sublingual nitroglycerin, indicating persistent ischemia with ongoing coronary vasospasm or refractory anginal pain, the escalation is intravenous nitroglycerin infusion, which allows precise titration of venodilation and coronary vasodilation. If pain remains uncontrolled despite IV nitroglycerin, intravenous morphine is added. Morphine acts through both analgesic and venodilatory mechanisms. It binds opioid receptors to reduce pain perception and simultaneously causes peripheral venodilation that reduces venous return and cardiac preload. A critical caveat: the OASIS-7 registry data suggested morphine may delay P2Y12 inhibitor absorption. It is therefore reserved for genuinely refractory pain, not routine analgesia. Complication 2. If the patient becomes hemodynamically unstable, hypotensive and bradycardic, typically from inferior STEMI involving the right coronary artery and its nodal branches, intravenous atropine is administered. Atropine is a competitive muscarinic antagonist that blocks the parasympathetic nervous system's vaguely mediated bradycardia, increasing both heart rate and blood pressure. Complication 3. If pulmonary edema develops, bibasal crackles, oxygen desaturation, frothy sputum, indicating acute left ventricular decompensation from massive anterior wall ischemia, intravenous furosemide provides urgent diuresis to clear pulmonary fluid and reduce pulmonary capillary wedge pressure. The entire STEMI management strategy is driven by a single overriding biological imperative: time to reperfusion. Because the amount of myocardium salvageable by opening the occluded artery decreases exponentially with every minute of continued ischemia. This relationship is captured in the phrase "time is muscle" and is operationalized in the two critical time thresholds that govern the reperfusion decision. Within 12 hours of symptom onset, the ischemic myocardium, though injured and electrically stunned, retains cellular viability. Myocytes in the ischemic penumbra around the central infarct zone have not yet undergone irreversible cell death. Reperfusion, by either percutaneous coronary intervention or thrombolytic therapy, can open the occluded vessel, restore oxygenated blood flow, and salvage this vulnerable myocardium. The specific target benchmark for PCI is the door-to-balloon time of 90 minutes, meaning from the moment the patient arrives at the emergency department to the moment the angioplasty balloon inflates inside the occluded coronary artery, 90 minutes is the maximum acceptable interval. This benchmark is a core quality indicator for every STEMI-capable hospital worldwide and is directly linked to patient survival outcomes. Beyond 12 hours, the point of no return, the ischemic myocardium has undergone complete, irreversible coagulative necrosis. The dead tissue cannot be resurrected by reperfusion. At this point, PCI and thrombolysis are not only ineffective, but potentially harmful. Reperfusing a completed infarct can cause hemorrhagic transformation, reperfusion arrhythmias, and myocardial rupture.
3 reperfusion strategies exist for STEMI, and the selection between them is one of the most consequential clinical decisions in emergency cardiology. Percutaneous coronary intervention, PCI, is the unambiguous gold standard and first-choice reperfusion strategy for all STEMI patients presenting within 12 hours, provided it can be performed within 90 minutes of hospital arrival at a PCI-capable center. The mechanism is mechanical. A guiding catheter is advanced through the femoral or radial artery into the coronary ostium, a guide wire crosses the occlusion, a balloon catheter is advanced and inflated to crush the obstructing thrombus and plaque, and a stent is deployed to scaffold the vessel open and maintain patency. PCI is superior to thrombolysis in every outcome measure: TIMI flow restoration, reinfarction rate, stroke risk, and mortality. Thrombolysis, using tissue plasminogen activator, such as alteplase or tenecteplase, or streptokinase, is the bridge therapy deployed when PCI is unavailable within the 90-minute window, typically because the patient presents to a non-PCI-capable facility requiring transfer. Thrombolytics enzymatically dissolve the fibrin matrix of the occlusive thrombus, restoring some degree of flow. The critical risk of thrombolysis is thrombus fragmentation. Breaking the clot produces debris that can embolize to downstream smaller vessels, causing microvascular obstruction and, in rare cases, precipitating a secondary myocardial infarction or stroke. CABG, coronary artery bypass graft surgery, is reserved for patients with triple vessel disease or left main artery disease who require complete surgical revascularization, where PCI of all affected vessels is technically suboptimal or anatomically unfeasible.
Following successful PCI and stent deployment, a new and potentially fatal threat emerges: stent rethrombosis. And understanding its mechanism, clinical significance, and prevention strategy is essential for post-procedural patient safety. The biological trigger is straightforward. A stent is a metallic foreign body within the native coronary vasculature. The coagulation system and platelet activation pathway recognize any foreign surface as a site requiring hemostatic sealing. Platelets begin aggregating onto the exposed metal struts of the stent, initiating thrombus formation. If this process proceeds unchecked, it builds a massive intrastent thrombus that re-occludes the artery just as completely as the original plaque rupture did, but with even greater lethality, because the recurrent event occurs in an already injured, already ischemic myocardium with reduced tolerance for additional insult. Stent rethrombosis carries a mortality rate of 25 to 45%, dramatically higher than the initial STEMI event, because it occurs in the context of severely impaired left ventricular function and depleted physiological reserves. The most critical clinical fact: if stent rethrombosis occurs within the first 12 months after implantation, the number one cause is patient non-compliance with antiplatelet medications. The patient stops taking their aspirin or clopidogrel, sometimes because of minor gastrointestinal discomfort, sometimes due to cost, sometimes due to a misunderstanding, and within days, the unprotected stent surface recruits a lethal intraluminal thrombus. This makes antiplatelet compliance education at discharge not merely important, but life-critical. The pharmacological shield against stent rethrombosis is dual antiplatelet therapy, DAPT, and its precise duration is determined by the type of stent implanted, making this one of the most frequently examined topics in cardiology examinations. DAPT consists of two antiplatelet agents with complementary mechanisms. Aspirin, which irreversibly inhibits cyclooxygenase 1 to block thromboxane A2-mediated platelet aggregation, combined with a P2Y12 receptor inhibitor, most commonly clopidogrel, but ticagrelor or prasugrel are used in higher-risk patients for their more potent and faster-acting platelet inhibition. The duration of mandatory DAPT therapy is stent-type specific. For a bare metal stent, a plain metallic scaffold with no drug coating, DAPT must be maintained for a minimum of 30 days. Bare metal stents undergo endothelialization, the process of native endothelial cells growing over the metal struts, relatively quickly, reducing the thrombogenic surface exposure to approximately 1 month. For a drug-eluting stent, a stent coated with an anti-proliferative drug such as everolimus, sirolimus, or paclitaxel that prevents neo-intimal hyperplasia and in-stent restenosis, DAPT must be maintained for a minimum of 12 months. Drug-eluting stents delay endothelialization because the anti-proliferative coating inhibits the same cell growth that would cover and passivate the metal surface. This leaves the stent biologically exposed and thrombogenic for a much longer period. The clinical imperative at discharge: every patient must receive explicit, documented education that stopping either antiplatelet medication before the mandatory duration is complete may cause a fatal heart attack. Surviving a STEMI is a medical achievement. Surviving the years after a STEMI requires a systematic, evidence-based secondary prevention framework that addresses 3 simultaneous pillars: essential pharmacological therapy, strict vital parameter control, and comprehensive lifestyle modification. The essential pharmacology at discharge consists of 3 cornerstone agents. Aspirin is maintained indefinitely as long-term antiplatelet therapy. It has been shown in meta-analyses to reduce the risk of recurrent myocardial inflation, stroke, and cardiovascular death by approximately 25%. Beta blockers are continued long-term to provide sustained antiarrhythmic protection, reduce cardiac remodeling, lower heart rate and myocardial oxygen consumption, and prevent sudden cardiac death, the landmine of the post-infarct period. Statin therapy at high intensity with atorvastatin 80 milligrams continues indefinitely to lower LDL cholesterol below the post-STEMI target of 70 milligrams per deciliter, stabilize existing vulnerable plaques, reduce vascular inflammation, and prevent recurrent coronary events. Vitals and systems control requires strict blood pressure management, targeting below 130 over 80 millimeters of mercury, as hypertension accelerates vascular wall stress and promotes recurrent plaque rupture. In diabetic patients, tight glycemic control is critical because hyperglycemia impairs endothelial function and promotes platelet hyperreactivity. Lifestyle modification is non-negotiable. Absolute smoking cessation. Smoking a single cigarette after STEMI significantly elevates the risk of rethrombosis. Combined with a Mediterranean-style low-fat diet, structured supervised cardiac rehabilitation exercise, and patient education on warning symptoms. We close with the master STEMI algorithm, a single, unified flowchart that integrates every clinical decision point in this entire lecture into one cohesive, executable protocol. The algorithm begins with the diagnostic confirmation: crushing chest pain plus V1 to V4 ST elevation plus elevated troponin equals STEMI confirmed. The cascade activates immediately. Step 1 is acute stabilization. Simultaneously administer oxygen if saturation is below 90%, aspirin 325 milligrams, clopidogrel loading dose, sublingual nitrates, beta blockers if no contraindications, high-dose statin, and low molecular weight heparin anticoagulation. Step 2 is complication triage. Assess for and address the 3 emergencies. Persistent pain unrelieved by sublingual nitrates escalates to IV nitroglycerin and IV morphine. Hemodynamic instability with bradycardia and hypotension triggers IV atropine. Pulmonary edema triggers IV furosemide. Step 3 is the reperfusion decision, the pivotal time-sensitive bifurcation. Within 12 hours, activate the cath lab and perform PCI within 90 minutes. If PCI unavailable, administer thrombolysis.
Beyond 12 hours, myocardium is irreversibly dead. PCI and thrombolysis are ineffective. If triple vessel disease is identified, refer for CABG. Step 4 is the discharge protocol. Prescribe DAPT at the appropriate stent-specific duration. 30 days for bare metal, 12 months for drug-eluting, plus lifelong aspirin, beta blocker, and statin, plus strict blood pressure and glucose control, plus smoking cessation and cardiac rehabilitation. Please like, comment, share, and subscribe to Studious for more high-yield clinical content like this.